The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. Cancer Stories, The Art of Oncology presents Jason George, reading the essay, Talking to Children with Cancer, Sometimes Less is More, by David Coronis, published October 1, 2016.
I still remember the day I met Kinsey. It was Valentine's Day. I'd sneaked out of the hospital to get my wife a Valentine's Day card, taking my place among scores of other husbands and boyfriends in front of the rapidly emptying rack of cards. As I started browsing, my beeper sounded. It was the emergency room. We have a 15-year-old girl who complains of dizziness and numbness on the right side of her face. We got an MRI, and she has a big lesion in her brainstem. I remember thinking, please don't let this be a DIPG. DIPG, diffuse intrinsic pontine glioma, is an incurable disease, one of the few pediatric malignancies for which there is virtually no hope of cure. I returned to the emergency room department and reviewed the MRI, a large swollen mass filled with pons, a DIPG. I walked into Kenzie's cubicle in the emergency department and paused when I saw her, a classic American teenage girl. Long wavy hair, jeans and sweatshirt, head down, fingers flying nimbly as she delivered multiple text messages to her friends. I felt anguish thinking about what lay ahead for this beautifully normal child and her family. Am I going to be okay? She asked, and her gaze reflected both fear and surprise. I don't know. It's too early to say, I replied. Because if I'm not going to be okay, I don't want to know. Kinsey could not have said this more clearly. I reflected on those words many times in the months to come. We've learned it is better to inform terminally ill children that they are dying, because it helps them cope better, prepare for what lies ahead. They may sense something is amiss and feel more isolated and alone if surrounded by well-intentioned but silent adults. Back in 1971, Wechter et al. Explored the feelings of 16 terminally ill children with cancer between ages 6 and 10 years, most of whom had not been told they were dying. These children had higher levels of anxiety than age-matched chronically ill children, and through drawings and narratives, they told heartbreaking stories about heaven, death, feeling alone, and being angry. These findings were replicated by Spinetta et al. In a larger cohort of older children. 30 years later, Kreitzbergs et al. Reported that of 258 parents who did not tell their terminally ill children they were dying, 27% later had regrets, whereas none of the 147 parents who did tell their children regretted having shared this information. In fact, the pediatric community generally supports the idea of sharing prognostic information with children, even when it means telling them that they are going to die. Later that evening, her parents approached me and asked through weary and tear-stained eyes, "How bad is it?" I told them. "Please don't tell her. Not yet," they cried. "Please give us a little time to figure this out." I did just that, and so began our conspiracy of silence. Kinsey started on dexamethasone and was treated with radiation and temozolomide. She gained weight, became puffy, and struggled with headaches. Despite her physical woes, she was fiercely determined to be normal. She went to school, learned to drive, and went to the prom. But the disease took its toll. More and more missed days of school until she simply could not walk up the stairs or spend even half a day at school. Her parents were good souls, the kind of people you wish could be your friends had you not met them and developed a relationship under such tragic circumstances. To me, it seemed they struck the perfect balance between protecting their daughter and giving her the space that a 15-year-old needs. As Kinsey continued to decline, our team periodically broached the issue of discussing her prognosis with her parents. We feel an obligation to share with Kinsey what is happening to her, what is going to happen to her. No, replied her parents. To what end? She knows she is ill and not doing well. We have an open and wonderful relationship with her. She does not have unfulfilled wishes. She is not asking questions. She is not sad or anxious. We will know when it is time. And so again, I deferred the conversation. I was troubled by the lack of full disclosure, although admittedly it did not seem to trouble Kinsey. I talked it over with both my pediatric oncology and palliative care colleagues. I asked, how far should I push this? Opinions were definitely strong, but came down on both sides of the issue. Her parents know her better than we do. They are good people who made a strong case for withholding the information. She has a right to know. She's a mature, young adult. She hasn't given us a hint of having any need to know her prognosis. How can we assume she doesn't want to know if we haven't talked to her? I decided it was worth trying to explore her understanding of her prognosis. This approach often bears fruit with children and teenagers. In a series of 20 terminally ill children and adolescents who knew their prognosis, Hines et al. Found that they were better able to make good decisions about such matters as whether to die at home, take part in early phase trial, or choose to undergo cardiopulmonary resuscitation. I met with Kenzie and explored with her what she knew and what she wanted to know. With a parent's blessing to freely discuss and answer whatever questions she might have, I spent time alone with her at most of our visits. I remember one visit when her headaches had worsened and she had developed a facial palsy. What scares you the most? I asked. My face is weak. Does that mean I'm going to become paralyzed? No, I replied. It just means a tumor might be growing in that spot or the radiation is causing swelling there. I went on. Some kids, when they get sick like you and have scary things happen like this, they ask themselves, what is happening to me? What is going to happen to me? Am I going to be okay? Other kids like to take things a day at a time. I'm one of those kids, she quickly replied before I could even complete the sentence. One day at a time. And that stopped the conversation. When the headaches became more severe, we hospitalized Kenzie for better pain control. A head MRI showed the disease had exploded, and there was no doubt that she was dying. Her parents understood and knew it was time to talk to her. Alone, in a quiet room, they told her that the tumor had spread everywhere, that the doctors could not stop it. They told her that she was dying. She nodded in acknowledgement. They then gathered around the bed with her 4 older sisters, held her hand, lay with her, and hugged her. I know that evidence supports the practice of telling the truth and can recite the benefits of doing so, but let me tell you that when it comes to sitting down with a child, looking her in the eye, and telling her she is dying, it is impossibly hard. All that knowledge, accumulated wisdom, and experience flies out the window and is quickly replaced by a paralyzing heartbreak. This is even more daunting when the child or teenager offers no clues that she wants to know, or, as in Kenzie's case, tells us she does not want to know. Did she know what was happening and simply not want to discuss it, or at least not want to discuss it with me? Did I not push hard enough, thankful in some way for being given a pass on a difficult conversation? These are the questions that swirled through my beleaguered brain over the months I cared for Kenzie, and continue to swirl within me every time a child sends me signals that she does not want to discuss her poor prognosis. Not all children want to know their prognosis, and this seemed to be the case with Kenzie. In the United States, approximately 10% to 20% of adults with life-limiting illness do not want to know their prognosis. There is a paucity of data on children and their desire for prognostic disclosure. In one of the few studies that addresses this, 100 survivors of childhood cancer between the ages of 11 and 20 years were surveyed on various aspects of end-of-life care. 96% felt that a child has a right to know if he is terminally ill. When asked if they themselves wanted to know if they were terminally ill, 85% said they would, 12% replied no, and 2.5% were not sure. So it seems that children, just like their adult counterparts, generally want to know, but also a small minority do not want this information. So what are we to do when a child like Kenzie, a child with little or no hope of recovery, tells us she does not want to know what is likely going to happen next? There are plenty of guidelines to guide our prognostic conversations, but little to help us when a child opts not to know. Let me offer some thoughts that helped me in my struggle to find that elusive balance between truth-telling and respecting what Kenzie wanted. 1. Ask yourself, does the child truly not want to know? Because most adults, and presumably most children in the United States, want to know if their prognosis is poor, we should not take an initial request to withhold this information as a final answer. We should respect that request, but at the same time revisit and re-explore and not necessarily breathe a sigh of relief over a hard conversation diverted. I think we ought to focus on building a solid, trusting relationship that allows for fluid communication at all times. 2. Ask yourself, does the child know? It is likely that many terminally ill children know their prognosis is poor, but find it too scary to talk about it openly. Children may drop clues that they know, such as references to deceased relatives or pets, and questions to their parents about their future. Children who are inordinately anxious and depressed and do not want to discuss prognosis may be in particular distress and might benefit from gentle pushing for a prognostic discussion. 3. Seek permission from the child and her parents before delving into a serious discussion about prognosis. Ideally, this should occur at 2 levels. First, the parents need to assent to a conversation with the child, preferably alone, and then the child must agree. Helping parents feel included is important and serves as a venue for them to request limitations on what is actually discussed. They may ask that any discussions of poor prognosis or death be avoided. I typically tell parents that I will try to honor their request, but will respond truthfully to the child if he or she asks about prognosis. 4. Ask to talk to the child alone. Many children protect their parents by not discussing with them the things they are worried about. Talking to a child alone sends a message to the child that she matters and that we are giving her the time with us so her voice can be heard. 5. Ask the child why he does not want to know. This may be a difficult question for a clinician to ask a child, but it is an effective approach to get at what a child is thinking and to give us valuable information about how best to approach the topic in the future. 6. Ask yourself if you could be harming the patient by avoiding the conversation about its prognosis. Sharing prognosis, even with children, is the norm in our culture. If we cannot find a compelling reason to inform the child who does not want to know the information, as Kenzie's parents pointed out to us, we might feel more comfortable with this approach. 7. Get help. We need to keep in mind our limitations and turn to members of our healthcare team who know and understand children in ways we do not. Although I fully understand that it is my responsibility as a child's physician to be the one to share a prognosis, there are others who can bring solace and comfort and provide guidance. If there is a friend, parent, or other relative, chaplain, nurse, child life specialist, or social worker with whom the child is particularly connected, then it may be better to have them take on the task of sharing prognostic information. 8. Respect the child's request not to know prognosis. Although we may think a child would benefit from a more open discussion about prognosis, it is imperative that we honor his or her request to refrain from that discussion. It is possible that in simply asking a question about prognosis, there is implicit messaging that the news is not good. That might be enough for some children to hear, at least at that moment in time. Guidelines, musings, wisdom, pearls, and the counsel of others are invaluable when it comes to disclosure or non-disclosure of prognostic information. But it is not enough. Communication works best when it is built on a relationship of honesty and trust and a continuous presence throughout the ups and downs of dreadful disease. Perhaps that is why Kenzie, her family, and our medical team ultimately were at peace with what was left unsaid in our many discussions with her. After Kenzie's parents told her she was dying, they asked her, "Kenzie, did you know all along that you were dying?" "Not all along. I knew things weren't good, but I just needed to hold on to hope." "Are you upset we didn't share this with you sooner?" they asked. "No, it is what it is. I love you guys." Her parents were then able to talk to her about her funeral. She requested the music that was to be played. She expressed concern about how they were doing. When her parents told her how much they were going to miss her, her response was, "I'll be there." She then drifted away into a world we do not know or understand and died the following day. I think we found the right balance with Kenzie. Our team talked to her parents, obtained their blessing to explore prognosis with her, talked to her alone, consistently made ourselves available to her and her family, talked amongst ourselves, and explored and re-explored with Kenzie. We consistently found a wonderful girl who was experiencing untold suffering, but who did not seem to be suffering from untold information. As I think about Kenzie and other children who balk at the prospect of discussing prognosis, I think it is okay for us to feel unsettled and unsure. We will not get this right every time. There may be some children with whom we share prognosis, but should not have. There may be others with whom we did not share prognosis, but should have. But as long as we remain keenly aware of the importance of exploring prognostic disclosure with children, as long as our focus is on what is best for that child, as long as we are asking the right questions to our parents, their families, and ourselves, perhaps we are getting it right.
I'm Lydia Shapira, editorial consultant for JCO's Art of Oncology and the host of this podcast. With me today is Dr. David Coronis, pediatric oncologist and palliative care specialist from the University of Rochester Medical Center and author of Talking to Children with Cancer, Sometimes Less is More, published in the October 1st issue of JCO. David, welcome to our program.
Thank you. It's good to be here.
I also want to thank you for your many contributions to Art of Oncology. As a contributing writer and reviewer, you've really brought a very important perspective to our board and to our readers.
Well, thanks.
You're very welcome. In your most recent piece, David, you deal with what I think is one of the most difficult aspects of communication in oncology, and you've structured this essay almost in two parts. There's a story, that's the story of Kenzie, and then there's your reflection that is more scholarly, where you really present a perspective on how to negotiate just how much information needs to be shared with an adolescent and her family who tell you that they really don't want to know. Can you start by sharing with our listeners a little bit about your story and how writing about it perhaps helped you process the very complex situation and feelings this situation triggered for you?
Well, sure. I think you're right. I don't think there's anything more daunting than having to communicate such horrible news to a child or to a teenager. And I also think there was this inherent tension in this when a child tells you that they don't want to know, because all our teaching is about being honest, full disclosure. So we have this force of what the standard is, and then the other side of it, a child who doesn't want to know, who doesn't want to go by our standard. It just creates a lot of tension in a situation that is already heartbreaking.
Yes, and you wrote it so beautifully, and I'd like to read for our listeners just a little bit of your essay. You wrote, "I know the evidence supports the practice of telling the truth, and I can recite the benefits of doing so. But let me tell you that when it comes to sitting down with a child, looking her in the eye and telling her she is dying, it is impossibly hard. All that knowledge, accumulated wisdom, and experience flies out the window and is quickly replaced by paralyzing heartbreak." I was really stunned by that. It's just so beautifully stated. Tell us a little bit about that emotional aspect of the experience and how you dealt with this paralyzing heartbreak.
And this is but one story. I feel like this happens almost every time where, you read the books, you read the articles, it's clear what you're supposed to do, but then reality sets in, and when you're sitting in front of a child and family, it just doesn't get any easier. And, on a personal level, it's just so utterly heartbreaking, and sometimes it is paralyzing. And I hope in writing about it, actually that helped free me of some of my paralysis, but I hope also in writing about it that I can let other people out there know that they're not alone.
Yes, in fact, I think that that's one of the very sort of useful aspects of sharing our stories, and it helps others connect. It helps us connect with our community of oncologists. And also by writing, I think that in many ways you helped us imagine and explore the point of view of Kenzie and her parents, which is something that we often don't have time to do when we're pressured to make decisions in the moment, when we're in the clinic or the hospital setting. So maybe it would be helpful to have you just tell us a little bit about Kenzie. Who is Kenzie, and tell us about her and her family.
Yeah, I think I wrote about her because, as I mentioned, she's not the only one that I have struggled with, that we all struggle with, but there was just something about this girl, and I think we probably all experience this with some of our patients. I wrote that she is beautifully normal, and she just could be any of our children. And so that takes it from the professional realm to the personal. Fingers flying on her cell phone, dressed like any other American teenage girl would be dressed. And that just added a layer of heartbreak to it. She was remarkable also in that she was just comfortable in her own skin. She's a girl who could live very comfortably in the the normalcy that her days at high school brought to her. She is a girl who was loved by friends and family.
Yes, and she's a girl who was so direct with you, right? And your team, you talk about the fact that she was very quick to tell you what she wanted to know and what she didn't want to know. Now, you met her on a Valentine's Day in the ER. Tell us a little bit about that first meeting.
Yeah, well, I mean, I think I wrote about this too, kind of an extra element of heartbreak. I mean, it was on Valentine's Day of all days, and there was this beautiful soft snow falling, and here I am out buying a Valentine's card for my wife when this horrible event unfolds. And I think what really struck me when I went to the emergency room is seeing this, again, this beautifully normal girl who just looked like any other American teenage girl. And I was kind of weighed down by what I knew lay ahead for her and the stark contrast between how normal her life had been up until that moment and how all of that was going to be shattered. And just the weight of that uneven distribution of knowledge, me knowing what lay ahead and her family not, just added to the heartbreak.
That's such an important aspect of the delivery of bad news. Just when we as the oncologists, we know it, we're holding it, and we know things that the patient and her family don't know, and know just how this is going to affect them, and then, finding a way perhaps of getting past that to connect in a helpful way. You speak a lot about the fact that this relationship worked because there was a lot of trust. And I imagine that's what you felt at the beginning as well, that this was your one and only opportunity really to connect and start building that trust that would guide you and the family and keep you going as events unfolded and as you knew predictably that things would get worse and worse.
Yeah, and I think I also knew that I have to earn that trust, that trust doesn't come from walking in the room with whatever credentials I might have. That one has to develop it and earn it and work for it. And it all starts by listening.
Yes.
And part of that listening was honoring what she wanted to know and didn't want to know and what her parents felt would work best for her.
Yes, you talk and you write about saying that it's okay for us to sometimes be unsure and to feel unsettled. I wonder if you could tell our listeners a little bit about how you and your team negotiated this over time. It seems that you sort of went back and forth and tried over and over to assess just how much they needed and wanted to know. Tell us a little how that actually worked out.
Yeah, you would think when, I write that Kenzie clearly didn't want to know, and we think, well, what's the big deal? We explored that. She doesn't want to know what's going to happen to her, and case closed. But it just wasn't that simple. For one thing, in real time, when you're in the thick of it, it's always so weightier and so much less clear than it is in hindsight. And for another, I think that it was so unusual for us to have this mature teenager where we knew what the path was, and yet she didn't want to know what that path was herself, or at least she didn't want it in her face. And I think because it was so far from what we're used to, we wanted to make absolutely sure we weren't missing something. One thing I struggled with is, am I just taking what she says at face value, not exploring it enough so that I can avoid having those awful conversations? I think I might have mentioned this. Am I just eager to jump at a pass on a hard conversation? Or is this truly what she wanted?
Yeah.
And I think in the end, it takes a lot of back and forth with her parents, and with our team to make sure we were on the right path.
Yeah. So in our final 30 seconds, can you tell a little bit or speak a little bit about how writing about this helped you perhaps to clarify your thoughts or process this very complex situation?
Absolutely. It helped tremendously. I think just on a raw emotional level, it provided a release. On another level, it just helped me think about this more methodically, systematically, not to get rid of the emotion, but to have rational thought as part of the process. And it was just a nice way to honor a remarkable young girl.
Thank you. That was David Coronis talking about his most recent essay, Talking to Children with Cancer. Sometimes less is more. Join me next time for a conversation about the art of oncology.